The broadcast is now starting. All attendees are in listen-only mode.
Hello, everybody. My name is Mike Willett at the National Native Network. Welcome to the National Native Network's webinar series on cancer risk reduction in Indian Country. This webinar is titled CDC's Cancer Control Efforts in Indian Country. This technical assistance webinar is being hosted by the National Native Network with the Indian Health Service, Health Promotion and Disease Prevention, which offers technical assistance and resources for commercial tobacco prevention and control throughout Indian Country, and the Indian Health Service Clinical Support Center. Your presenters today are Donald Haverkamp from the CDC, Lieutenant Andrea Carpitcher from the Cherokee Nation, and Chad Ratigan, Program Manager with the Great Plains Tribal Chairmen's Health Board. Donald Haverkamp has a Master's in Public Health from San Diego State University and a Bachelor of Science from the San Diego State University. Lieutenant Andrea Carpitcher is the Program Director for the Cherokee Nation Breast and Cervical Cancer Early Detection Program. In 2015, she earned her Master of Science in Nursing from Northeastern State University. In 2010, she earned her bachelor's in nursing, and in 2000, she earned her associate's in nursing from Bacone College in Muskogee, Oklahoma. And Chad Ratigan is a project manager with the Great Plains Tribal Chairmen's Health Board. In 2018, he earned his Bachelor of Science in Healthcare Administration from Walden University in Minneapolis. We are pleased to offer continuing education credits for participants in this webinar. No commercial interest support was used to fund this activity. This activity is designated one contact hour for nurses. And to obtain a certificate of education, you must be registered for the course, participate in the webinar in its entirety, and submit a completed post-webinar survey. We will be sending out the post-webinar survey in an email that will be followed up tomorrow out of the GoToWebinar platform. So just click the link that you'll receive tomorrow within 24 hours of attending this presentation. By the end of this webinar, participants will be able to examine the CDC's Division of Cancer Prevention and Control data on cancer in American Indian and Alaska Native populations, and implement strategies and key interventions to prevent and detect breast, cervical, and colorectal cancer in American Indian and Alaska Native populations. If you have any questions, please type your questions into the question box on the lower right-hand corner of the screen. Questions will be answered during the last few minutes of the webinar. Thank you, and now at this time, I'm going to throw it over to Donald Haverkamp.
Thank you, Mike, for the introduction. My name's Don Haverkamp. I'm an epidemiologist with the Division of Cancer Prevention and Control. I'm actually a field assignee out in Albuquerque, New Mexico, and I work with IHS and tribes to improve colorectal cancer screening primarily. But today I wanted to give, just take a few minutes to give you an overview of our division at CDC, which is based out of Atlanta, and just a few of the programs that each of the branches within the division focuses on, and how those can be utilized by people in Indian country through those programs. I won't go too much into this slide. This is a logic model that talks about, it just shows all the planning that goes into our division, thinking about what they want to focus on and what their strategies and priorities should be for the division to reach that that all-important goal of having all people free of cancer. That's the main thing we're shooting for. To do that, our division of cancer prevention and control consists of 4 branches, which you can see on this slide. And I will just take a brief flyover of our division and what programs are contained within each one of these branches and how they can impact Indian country as well. The first branch we'll talk about is a comprehensive cancer control branch. And they're really mainly known for managing the National Comprehensive Cancer Control Program, which was established back in 1998, so 20 years into that program. And you can see some of the bullet points on the right. Just in a matter of time, I won't go through all these, but these are kind of the strategies that are used to promote ways to decrease cancer in communities. This program really is a strategic approach to preventing or minimizing the impact of cancer. And they use a collaborative approach and work on really building coalitions in their communities. You can see some of the organizations that are currently being partnered with in various communities and states and tribal organizations to build these coalitions of stakeholders. This program is available funded in all 50 states and territories and some tribes as well. This slide shows the tribal organizations that are currently funded under the Comprehensive Cancer Control Program. The 8 that are listed here, and on the right you can see kind of where they are located in the country. And then at the bottom, these slides will be available to everyone after the webinar, but there's actually a link here to the Comprehensive Cancer Control plans where you can go in and search for any of these plans and see what they've come up with as far as their strategy and what cancers they want to focus on, etc. The next branch is the Cancer Surveillance Branch, best known for their managing of the National Program of Cancer Registries, or NPCR, in which they're collecting data of all types on all cancer patients in the states that they fund, collecting data on type of cancer, location of cancer in the body, what stage the cancer was detected at, type of treatment that was given to the patient, outcomes of that treatment, etc. A little bit more about this registry program that was established in 1992. It currently is funded in 46 states and DC and the territories of the US. And with all of these projects being funded, or states being funded, we're able to collect information on 1.6 million new cancer cases each year. And as you can see, this isn't a nationwide reach, but when it's complemented by another project or program from the National Cancer Institute, the SEER program, Surveillance, Epidemiology, and End Results program, we are able to actually capture cancer incidence data for the entire US population, including Puerto Rico. The map on the right just gives you an idea of the states in light blue that are funded by the NPCR registries, and the NCI registries are states in the kind of the tan color, and then the striped states indicate states that have both CDC and NCI registries. And all this data is compiled into a public use data set called the United States Cancer Statistics data set, and that's available at the website you see below. Now, with these cancer registries and other vital statistics databases, we found that there is an issue with race misclassification, especially when it comes to American Indian Alaska Native people. Oftentimes they're misclassified as other races in these databases. So, and this varies quite a bit by states, but we've taken an approach to address this problem because it is especially a problem among American Indian Alaska Native people in the data that we have on them. To do this, we have Melissa Jim, who works in this branch, and she's here with me in Albuquerque working, and she conducts linkages with these NPCR and SEER registry data and links them with Indian Health Service administrative records. And we know these people are American Indian Alaska Native if they're associated with IHS. So by doing this, we're able to identify people who were classified as non-native when they actually are native, and we can correct that in the database of the registry data. And it seems to be well worth the effort. If you look at the slide, you can see the number of individuals who were classified in these databases, for example, before the linkage. In the dark blue of this bar, of each of these bars, the dark blue portion is the number of people who are already shown to be AIN. The tan part of the bar is all the people that were identified because the linkage was done, and we were able to clearly state that these are actually American Indian Alaska Native people. And this has a big impact when you're looking at calculating rates for cancers, for example. If you look at this slide, I don't want to get too bogged down in the data slides, but if you look at this one, you see in the blue bars, American Indian cancer rates before we did the linkages by different regions of the country, compared with the brown or whatever colored bar those are to the right of that with the calculated cancer rates after we did the linkage and identified more people who were American Indian Alaska Native in those data sets. So once we had this upgraded, or I guess improved data, we were able to go in and utilize that and do a number of publications in the past few years related to cancer incidence rates among American Indian Alaska Native in the cancer supplement, for example, as well as a more recent journal supplement in the American Journal of Public Health on American Indian Alaska Native mortality, because we did a similar linkage with the National Death Index. So we kind of updated their misclassification data as well. Another interesting tool that I'll just mention real quickly is this data visualization tool, where it's available online recently, and you can actually go in and look at this USCS data and really drill down to look at cancer rates and cancer trends and specific kind of cancers that are affecting your community, even down to the county level. And the exciting thing to mention on this webinar is that pretty soon there'll be another tab available for looking at AIAN data specifically in different regions. It won't be available at the county level necessarily, but you can go in and look by region at the different cancers that are a high burden in that area, for example. And this is data that's been aggregated for 5 years just to have a higher number of cases to look at and report on. And this will be updated yearly. And then we have the Epidemiology and Applied Research branch, which is where I'm working out of. This branch does not include or oversee a major program such as the NPCR or the Comp Cancer program, for example. But if you look at bullet number 2, I've highlighted that we tend to work with partners and such as IHS and tribes, in our case, here in Albuquerque, and we look at ways to really apply scientific knowledge to public health practice and even conduct some public health research across the cancer spectrum. And I'll give you a few examples of some of that we've done in our collaboration here in Albuquerque with tribes over the past decade or so. And again, a lot of the work I've done is focusing on colorectal cancer. We've seen that the burden of colorectal cancer is extremely high among Alaska Native populations. So a lot of the work we funded from our branch and division even has focused on trying to improve screening in Alaska. And the other region is the Northern Plains. But some of the projects we've just to scan on those real quickly. One of those is developing a colorectal cancer family history outreach project, where if a person was diagnosed with colorectal cancer, they would focus on identifying their first-degree relatives who are then identified as people who are at higher risk of developing cancer themselves. And to build on that, they even tried to hire patient navigators who were dedicated specifically to contacting those first-degree relatives and getting them in for screening to see what kind of impact that would have on screening rates. And if you look at this slide, you can see there's a pretty dramatic effect that was had just from hiring these patient navigators who are dedicated to cancer screening. You can see after the first navigator was hired in 2006, there was a significant bump up in the number of first-degree relatives screened, and then another big boost after the second navigator was added as well. So that's a good approach to take as far as screening improvement. Melanie Cueva and her group up in Alaska have also been really successful in coming up with some innovative projects to create awareness and to create educational tools for community health aides in Alaska. And those are all compiled on this website. They're the Community Health Aid Program website. And then finally in Alaska, we've even funded studies such as a study to look at alternative ways to screen for colorectal cancer in Alaska Natives who are primarily being screened through colonoscopy. And we looked at the use of a newer type of stool test, the fecal immunochemical test, to see if this was an effective way to screen this population, and had positive results from that study. And as a result, they've actually included this alternative recommended method of screening among the Alaska Native population over at Alaska Native Tribal Health Consortium. And we've taken a similar approach here in the Southwest, just funding another FIT study looking at practical ways to get people to get screened when they have limited access or live far away from clinics. We actually tried mailing out these FIT kits to folks and had some success in improving the screening rates in the clinics that were involved in the study, improving screening rates from about 6% in the usual care group up to 17% in the group that had been mailed the FIT kits, and even had a further boost in screening return when we had community health representatives involved and providing outreach and getting people in for screening. And this group has also developed a number of great resources for clinics and providers on colorectal cancer health, as far as PSAs and digital stories and flip charts, you name it, they have it on this website, and those are available as well. And then finally, just to, let me see, I think I'm running out of time, but I won't go through a lot of these slides, but the last branch is a program services branch. And this branch oversees the National Breast and Cervical Early Detection Program and the Colorectal Cancer Control Program, which is a newer program. And the breast and cervical screening program, it's worth mentioning, it's been in existence over 25 years now. And in that time, they've actually provided over 12 million screening exams to low-income, uninsured, and underinsured women around the country. And this program is available in all, or funded in every state. Let's see. Sorry, trying to advance my slide. And you can see here that there are also 11 tribal organizations that are also have their own breast and cervical programs in place as well, in addition to the state programs. And Andrew will be presenting on the Cherokee Nation and what they've been doing in their specific program in a few minutes. The colorectal cancer program is slightly different. It's a newer program and not so much focused specifically on providing direct services to screening, but more about encouraging screening and use of evidence-based interventions and focusing on targeted populations in their areas. And it's not, at this point, a national program. Currently, there are 30 grantees around the country that are funded. You can see the green is really the component means that they're just focusing their funding on promotion of screening. And the blue states have some leeway in spending some of their funding on direct services as well. And as you can see, there's the little diamond shape indicates the one tribe that was funded during this current funding cycle. And that's the Great Plains, and Chad will be presenting on that project here in just a second. So again, these are the major programs of the Division of Cancer Prevention and Control, and we try, some of these are available and working in all this in a particular state, and we try to coordinate and collaborate all these programs at one time. And finally, just a quick mention of other initiatives and campaigns that are available in our division. You can go on our website to learn more about these initiatives, and a lot of these are seen on social media. So finally, this is our website where you can find that information, and you can also follow DCPC online on Twitter and Facebook as well. So that's it for me. I'll turn it over to Chad to give more specifics on their colorectal cancer program.
Perfect. Thank you, Don.
Sure.
Oh, there we go. So like you said, I'm Chad Ratigan. I'm the program manager for the Great Plains Colorectal Cancer Screening Initiative. And in this presentation, I'm just going to touch on some updates that we have going on with our program and what to be successful in our areas. So a little history. The Great Plains Tribal Chairmen's Health Board was awarded a cooperative agreement from the Centers for Disease Control and Prevention to increase colorectal cancer screening rates within the 18 tribes and 20 facilities in our 4-state region. So that includes South Dakota, North Dakota, Nebraska, and Iowa. And then also the Great Plains American Indian men and women have the highest and second highest cancer incidence rates among all American Indian and Alaska Native population groups. So our screening initiative, like I said, it works in the 4-state area, and this is, a list of the different service units and hospitals that we work with in these tribal areas. I'm not going to go over every one, but this is just kind of a snapshot of everybody that we work with as a program. So our staffing and our coverage, again, the map on the right is just a picture of our coverage areas. And then our staffing includes our project director, which is Tinka Duran, myself, Eugene Gallego. He works with the North Dakota and some of the areas in South Dakota. And then Gina Johnson works primarily with the South Dakota region. And then Devereaux Yellow Earring works with the tribes in Nebraska and Iowa. And Eugene, Gina, and Devereaux are navigators. So they go out to our different events and really work hand in hand with the tribes. So in order to establish partnerships that support the increase of colorectal cancer screenings, these are some of the things that we do and that we continue to do on a weekly and monthly basis. So we have our quarterly Great Plains Task Force call, and this includes members from our 4-state area that we cover. And what we do during these phone calls is we bring somebody in for some educational aspects, and then we also get updates from people, if they have anything going on, what they're seeing working, what's not working. Then we have a lot of collaboration with our colorectal cancer screening programs and stakeholders. We network at our cancer symposium, which I'll touch on later. And then we have also established site visits where our navigators will go out and work with our subawardees and see what barriers they have, what's working for them, what they've seen as successes. and then our provider assessments, and then the flu fit program. And I'll touch more on the provider assessments and flu fit here in a little bit. So in order to increase our evidence-based interventions and supporting strategies, we're really looking at the patient reminders, community assessments in collaboration with ACS, and that's something that we're continually working on even right now. I'm trying to get those community assessments done. And then again, the provider assessments, and then the reduction of structural barriers per subcontract. The reduction of structural barriers is probably one of the biggest ones that we see just because of the areas that we work with are so rural, and trying to get people to come in and pick up the fit kits or even return them is something that we deal with quite often and something that they see out in their clinics. So in order to increase our high quality CRC screening rates among our Great Plains American Indians, we do work with and subcontract for implementation to increase these rates and get these EBIs done with the different tribes and the different units out in their communities. And we really concentrate on, again, reducing those structural barriers, the annual flu fit, the education and screening of FIT and FOBT, and the pre and the post surveys. So the annual flu fit and the education and screening. So we do events where we bring out our Rollin colon, and I'll show you pictures of that later. And then we really hit on the educational aspect, and we have somebody come out from the clinic and hand out the flu or the FIT and then the FOBT. And then at the end of that, we do pre and post surveys to gauge the educational aspect. So in order to increase adherence to timely diagnostic procedures and increase our rescreening times among patients, we're really concentrating on the flu fit, and this flow chart here kind of shows you how it works. We're really trying to increase our partnerships with states and tribes using this. And the reason why we're concentrating on this so much is that sustainability aspect. If we can get people to recognize that when they go in to get their annual flu shot, and they also need to pick up their fit kit in order to get screened, that's what we're looking at. And that sustainability aspect is extremely important for us. So in order to increase the supporting strategies of EBIs, these are some of the things that we have used and we've been successful with. So we have our CRC educational materials. We're really looking to increase the distribution. So we have a mass March mail out during Colorectal Cancer Awareness Month, and we send it out to all of our units that we have subawards with, so they can put them up in their hospitals and they can hand out that information, whether it's fact sheets or brochures. And then another thing we started doing is survivor stories. We have an online platform. If you go to our website and find our program, we do have survivor stories under there. And the biggest thing for this is it's important to have a survivor story from each community that we work with, because we'll find that it's relatable and people are more likely to do it if they know like a person from their community got it done and it was fine. And then our CRC resources really use our local and regional partners for information, you know, if something's working, if there's updated information that comes out. And then increasing technical assistance. So we have monthly check-ins and calls per our subcontract and with our tribal communities. And basically we call them monthly to check in and again, see what's working. You know, are they facing any other barriers? Do they need more materials? Do they need more fact sheets? Or do they have somebody they want to do a survivor story with? And then our evaluation of subcontracts implementation. This is something we do with Asset, and they are our evaluator, and they do it annually for us. And then the increased community education of all tribal facilities in the Great Plains region. So what this is, we bring out the Rollin colon, like I mentioned earlier. We do CRC 101, and then again, those distribution of materials. When we go to these different events, we like to bring our materials out to give out to the community members. Again, walking through that Rollin colon is important because it gives that educational aspect. You know, the Rollin colon has healthy colon material all the way to full-blown cancer. So those pre and post tests that we do there are also very important. So the provider assessments. So this is another piece for our EBIs. And the provider assessment and feedback interventions both evaluate the provider's performance in delivering or offering screenings to clients and present providers with information about their performance in providing those screenings. So it's all about the feedback. And we actually just got back last week from completing all of North Dakota service units provider assessments. So, but this is a list of all the completed provider assessments that we have done as a program. Like I said, we just got back from North Dakota. So that was Trenton, MHA, Spirit Lake, Turtle Mountain, and Standing Rock. So when we go do these provider assessments, these are some of the tools that we take with us. We do have a checklist for increased screenings. We have a detailed checklist, a checklist for follow-through, internal practice questionnaire, go over chart audits, a tracking template, and then we go over their GIPRA numbers and their reports. So these are the two major tools that we use. And these two books, How to Increase Colorectal Cancer Screening Rates in Practice, and then Steps for Increasing Colorectal Cancer Screening Rates, are important. And that's where we pull a lot of the information that we use to go over during the provider assessments. And they're designed for internal clinic use. And we do bring copies of these books to the actual provider assessments that we go and do, so that each provider or nurse or anybody who comes to the assessment can take a copy with them. So the checklist for increased screenings. So the picture on the right is kind of a snapshot of what that checklist looks like. And we go over this at each site just to see, what does it measure? It measures the changes in colorectal cancer screening policies and procedures, who administers. So someone who can answer each line. So the people that we have at our assessments and our meetings, we really want them to be somebody who can answer these questions that we go through, whether it's the doctors, the nurses, even administration staff. And then how can this information be used? So the pre and the post assessment of colorectal cancer screenings office processes. So we go through this entire checklist with them, and we go over whether it's fully in place, in progress, or not in place. And we take notes, and then we go over that, and we actually send this to them at the end of it. So the entire assessment, takes 60 to 90 minutes, depending on how many staff are there. So the system in action. So like I said, we go over the assessments with the status of the clinics, and they're able to, at the end of that, we go over it and we send it to them. And if they have any questions on it, it really shows, where they can help increase their colorectal cancer screenings. So it's very useful. All the staff are open to it, and it's a nice thing. Some of the strategies we use while we're there, a lot of the planning and reminders, and we order food, because if there's food, generally people will come. And we always have two facilitators and somebody also there to take notes, because it's a lot to do just for two people. But the items that we bring include those two books. This year, we actually put a lot of stuff on the jump drive so they can digitally have it. And then we also bring a PowerPoint with our hyperlinks to go over. So when we click on them, it just pulls up on the projection screen, and they're able to see it and interact with it. And we think that helps. So the agenda topics that we go over, we always do introductions and icebreakers so everybody's comfortable and they know who's in the room, the what, why, the how, and next steps. And then at the end, we do a reflection and a debrief if anybody has any questions. So this is some of our subawardee feedback. When we do these subawards, we like to get their feedback on how things are going and how we're doing, where we can improve. So some of these are just comments from them. The staff provided support in implementing EBIs. The materials we shared were valuable. The community grants were instrumental in increasing screening rates. And then the challenges were noted. So again, it's, we look for those barriers and how we can work through those. This quote at the bottom is from one of the providers. And it's just nice to hear. The CRC screening, like I said, it wasn't the priority that it should have been here, not only with myself as a provider, but the whole medical staff in general. I think our community grant, 100% was 100% responsible for our increased screening rates, in addition to bringing colon cancer screening to a priority that it wasn't before. So one of the other things we had this year was our 2018 Cancer Symposium. We had over 100 individuals come from it, and we actually had representation from every tribal community in the Great Plains region. So that included North Dakota, South Dakota, Nebraska, and Iowa, which was fantastic. And then we had our social media campaign at the actual symposium. It was hashtag GP Fights Cancer, and it was very popular. Some of the topics that we covered are listed there. Again, it was a good networking for everybody to come together, and learn together. And we made a lot of different contacts, and we really look forward to next year's. So Colorectal Cancer Awareness Month is every year in March. So we created a campaign as a program to encourage tribal communities to raise awareness about colorectal cancer. So we have a photo contest that requires participants to support colorectal cancer by taking a group photo wearing blue. And these are some of the pictures from that contest. As you can see, everybody's dressed in blue. They make signs. They have a lot of fun with it. It's something that's been very successful, and it brings awareness to those communities. And we use the hashtag #ShowYourBlueGP, and it's been fantastic. This is Spirit Lake, Ponca Tribe, and then Fort Yates. And on the next slide here is another group. They are the Omaha Tribe of Nebraska and the McLaughlin IHS. And again, it's just about wearing blue and really bringing that awareness out into communities. So these are the Rollin events I'd mentioned earlier. This is kind of what our setup looks like when we go out to the communities. Right here, the big Rollin is what we have. And again, it has healthy colon tissue all the way to full-blown cancer. And we do the pre and the post tests with people when they come and take a tour. We walk them through it. We give them different facts and statistics. And then at the end, they take a post test. And that's how we really gauge the educational piece if we're educating the communities. So this is the pre and the post data. Like I said, with the Rollin colon, this is what we use. As you can see, majority of the categories below from the pre to the post have increased, which means that when we walk them through that they are learning different aspects about colorectal cancer. And these were our CRC screening rates, baseline from year 1 to year 2. As you see, they are going up. So the education and the different events that we are going to are working, and the things that we're doing in the communities are helpful. You know, we're still looking to increase the screening rates and all that every year. But right now, this is something that we can celebrate because it is working. So this was our, sorry about that. That was our picture for Show Your Blue GP as a staff, as an organization. But thank you guys for your time. I appreciate it. If you have any questions, feel free to reach out. If not, I'm going to hand it over to Andrea.
Here we go. Theo Tohija. Hello, everyone, and good afternoon from the Cherokee Nation. Today, I'm speaking to you from our capital city of Tahlequah, Oklahoma. My name is Andrea Carpitcher, and by profession, I'm a registered nurse. I serve as an officer in the United States Public Health Service Commission Corps, and I am a very proud citizen of the Cherokee Nation. As the program manager for our breast and cervical cancer early detection program, I will be presenting to you an overview of how Cherokee Nation Health Services operates to put hands and feet to work to carry out the vision of the CDC and the National BCC-ED program to ultimately identify and implement unique strategies to control breast and cervical cancer that will be most effective amongst our Native people within the Cherokee Nation of Oklahoma. At Cherokee Nation, our mission is to promote health and quality of life among our communities and families through culture, collaboration, community engagement, and empowerment. Cherokee Nation is dedicated to promoting and improving health to ensure healthy communities for this and our future generations. Here is a map of our service area across all the Cherokee Nation. We are now the largest tribe in the United States. Our tribal jurisdiction area covers 14 counties in the most northeastern part of the state. I would say the most beautiful part of the state. We are currently at over 355,000 enrolled tribal members, and over 110,000 Native Americans live within our jurisdictional area as well. The tribe operates a full health system of 8 outpatient health centers and 1 hospital. It was reported in 2016 that we saw 1.1 million outpatient visits. And exciting things going on right now at Cherokee Nation this year. The tribe began construction on a brand new 469,000 square foot outpatient facility. It's projected to be complete in 2019 as the largest tribal facility in the country. So the current statistics tells us that 1 in 8 women will get breast cancer in their lifetime. And within the Cherokee Nation, breast cancer is the most frequently occurring cancer among women. We also recognize that American Indian women are 2 times more likely to develop cervical cancer than white women. So in response, the National Breast and Cervical Cancer Early Detection Program, a CDC-funded grant, was authorized by the Breast and Cervical Cancer Mortality Prevention Act of 1990 and was amended in 93, creating a specific initiative to target American Indian and Alaskan Natives. We at Cherokee Nation are one of 2 tribes funded under this grant in the state of Oklahoma. In 2001, Congress expanded the Breast and Cervical Cancer Prevention and Treatment Act and passed the Native American Breast and Cervical Cancer Treatment Technical Amendment Act, explaining that this option also applies to American Indians and Alaskan Natives who are eligible for health services provided by the Indian Health Service or a tribal organization. In other words, it means that IHS eligibility is not considered third-party coverage as related to Medicare, Medicaid, and private insurance. Since our program's inception in 1996, we have enrolled 24,296 women, performed over 34,000 Pap tests, and nearly 37,000 mammograms, all under this CDC grant program. The guidelines that we have in place for our program eligibility are they must be Native American, between 21 and 64 years, generally for cervical screening, and 40 to 64 years for mammograms. They can't have any third-party coverage. And again, the IHS eligibility is not considered third-party coverage. They must be at or below 250% of the federal poverty guidelines. And they don't necessarily have to be an Oklahoma resident or reside within the jurisdictional area. The services that are covered under our program include clinical breast exams, mammograms, Pap tests or pelvic exams, diagnostic testing, if their screenings become or come back abnormal, and also patients that reside outside of the state of Oklahoma are covered under our specific program with Cherokee Nation. We have an additional resource available that supplements us with Oklahoma residents, and I'll speak a little bit more about that later on. We also provide women's health case management, which includes making referrals for treatment, follow-ups, health education, and community outreach activities. Focusing toward our strategies and key interventions, we partner with various Cherokee Nation health and Cherokee Nation programs in efforts to reach additional eligible clients, collect and share data to bring awareness to patients, providers, administration, and so forth regarding the increasing incidence of breast and cervical cancer in the Native American population, and specifically within our Cherokee population. We have access to cancer incident rates, reports by the Cancer Tumor Registry program that Cherokee Nation operates. And Donald had spoke some about the cancer tumor registries earlier. I'm having an issue getting to the cursor. Okay, one of our most recent efforts that is still in the early stages right now is an opportunity to provide breast and cervical cancer education to audiences of women that are presenting for breastfeeding education classes at our tribal hospital and community centers. This is an opportunity for us to educate women on the risk associated of breast cancer by not breastfeeding. Cherokee Nation recently received the distinguished designation of a baby-friendly hospital. I have a background in OB care, and so this is very exciting to me, how this piece of information can sometimes get glossed over, but we're able now to get in front of these women from a cancer standpoint so that greater attention is being brought to this and the importance of breastfeeding. Our goal is to strengthen the numbers of Cherokee women electing to exclusively breastfeed and to broaden the reach of our program to more eligible women. In addition to be a present face in the community where we feel our greatest need for impact is, we have public health educators who are trained and well-versed in breast and cervical cancer who are going out to the community commons areas and outreaching to program eligible women. When they go out, they give a presentation, but they're also now implementing a pre and post knowledge awareness survey where we're able to hopefully gather some data about what the base knowledge is about breast and cervical cancer and the attitudes that women have about why they don't come in and what barriers they may have for coming. The sites that they are going to, in addition to the clinical setting, is we have food distribution centers all throughout the Cherokee Nation. They're able to go there and they're able to reach out to staff as well as the tribal members coming in there on a daily basis. Also the daily nutrition centers where our people are gathering to eat and share meals. We're able to go in there and meet with them face to face. We're actually seeing that this is in fact reaching women who maybe aren't seeking routine care. They're also getting in the clinic and just meeting people face to face who are in the waiting room, in the lobby areas, women who are maybe just there with their children or their grandchildren who aren't otherwise coming into the clinics for themselves. We're currently tracking these efforts for effectiveness and how many of these women that we are able to get referred to an appointment. And this information is given from the public health educators to our patient navigators, and they're able to follow up then and see how many we're able to screen from these efforts and how many of them are keeping their appointments and their follow-ups. When we're out in the community meeting these women face to face, it gives us an opportunity to expand and to explain the individual risks that they face as rural Native American women and what we are standing ready to do for them. Through the grant program, we are able to pay for regular breast and cervical cancer early detection screening services, provide case management and patient navigation services, conduct education sessions specific to breast and cervical cancer, and connect them to outlying resources such as support groups And we also have excellent contacts of companies who assist breast cancer patients in obtaining wigs. Another thing that we do is host an annual breast cancer survivor banquet that allows our Cherokee Nation survivors to connect and share their experiences and offer one another support in the comfort of their own familiar cultural environment. This all brings me to the talk about the Oklahoma CARES Breast and Cervical Cancer Treatment Act. This was implemented in January 2005. It's an interagency agreement of 5 agencies, including the Cherokee Nation, the Kaw Nation, Oklahoma State Department of Health, Oklahoma Healthcare Authority, and Oklahoma Department of Human Services. This is an additional resource to our health system that provides reimbursement for breast and cervical diagnostic or treatment services for program eligible women. That is all that I had to talk about today. And there's my contact information. If anyone would like to reach out to me directly about our program, I would love to hear from you.
Awesome. Thank you very much, Andrea. Thank you, Chad and Donald, for your kind presentation today. This is Mike Willett with the National Native Network again, and we'll go ahead and start taking questions and answers out of respect to everybody's time. I think that we're only going to get to probably about 1 or 2 questions, so go ahead and type them into your question box there on the lower right corner of your screen, and then go to webinar control panel there, and type in your questions, and I'll go ahead and ask them aloud for our presenters. The first question that we have here says, do you know who has the highest rates of cancer among us Native people?
This is Don. Am I unmuted? Can you hear me, Mike?
Yep, I can hear you just fine. I think Chad and Andrea are still muted. Yep.
Yeah, I think it depends on the tribe and the region. We see a lot of variation among cancer rates depending on the region of the country. For example, looking at colorectal cancer rates, for example, they're extremely high in Alaska, in the Northern Plains or the Southern Plains regions, where they're extremely low in the Southwest. And rates can vary depending on the type of cancer and the tribe you're speaking of. So I'm not sure you can really state which tribe or group has the highest overall cancer rate.
Okay. And like I said, if you have any questions, feel free to type them into the question box. We're going to try to stay firm on the 4 o'clock top of the hour here time limit, just out of respect to our presenters and respect to the audience as well. Also, if you're looking for an archive of the webinar, make sure you visit keepitsacred.org. I hope to have the webinar turned around in about an hour and get that up on the website. Check it out in the morning if you want. Go to keepitsacred.org, click resources on the left menu, and click webinar archives. And make sure to follow us on social media. This person says here that she's in Alaska. Thank you. She was wondering about the colorectal cancer, but didn't specify it. So she's wondering about, she's following up on her question, but she's targeting colorectal cancer.
Well, yeah, I'm not sure of the specific question, but maybe she's referring to why the rates may be so high in Alaska compared to other regions. If that's the case, there's probably number of factors that influence the colorectal cancer, such as smoking and diet and lack of exercise, those sort of factors. So it's kind of a multifactorial type of situation there with colon cancer. I know smoking rates are extremely high among Alaska Natives and folks in the Northern Plains, and that's definitely a contributing factor. But there are probably other factors as well that are contributing to those high rates.
This question says here, regarding breast cancer survivor banquet, who all attends the breast cancer survivor banquet?
Hi, that list comes from our list of survivors that we track, and it's kind of an ongoing list from year to year.
This person says, besides federal and state funding, what other sources of funding do you use?
I can answer for our program at Cherokee Nation that we don't have any other additional funding.
Yeah, the Great Plains Tribal Chairmen's Health Board, we don't have any additional funding either for our program.
Okay. And again, if you have any questions, we still have another couple of minutes here. Feel free to type them into the question box, and we'll go ahead and ask those out loud. Make sure you follow us on social media, facebook.com/keepitsacred, twitter.com/keepitsacred, linkedin.com/company/keepitsacred, and on Instagram as well. We just opened up the Instagram account, and we do have a LinkedIn account as well to connect on your professional account. So make sure you follow us to stay up to date on upcoming webinars and newsletters. We'll have a new newsletter going out later on this month, and make sure you follow us on social media to stay up to date on all that. We're still waiting on any other questions. Did the panelists have anything that they wanted to add, or any websites they wanted to put out there for resources?
This is Don. I don't. I think I listed the ones that I would really recommend within my PowerPoint slides. So hopefully people can download those and have a look.
Okay. This person says, Great Plains, do you use grant funds to purchase the fit kits for the clinics?
That's it. The grant funds that we give out go, and they're supposed to work with the clinics and stuff, and the clinics get the fit kits or the FMBT kits, and then they get them to them. The money that we get is really to get the educational aspect out there and whatever they need to accomplish their EBIs. So no, sorry, that was a long answer.
Long answer with some explanation. All right. Well, I don't see any more questions coming in. So with that, I think we might want to go ahead and wrap it up. Looks like we can get out of here a little bit early. We want to thank Andrea, Chad, and Donald for being able to be our presenters today. And with that, we'll go ahead and bid everybody adieu. Also, we will be sending out a link tomorrow out of the GoToWebinar platform. And make sure to click on that link, complete the evaluation for us, let us know how we did on the presentation, and we can go ahead and get you all set up with continuing education credits, certificates from the Indian Health Service Clinical Support Center. So make sure that you keep an eye open in your email for the follow-up email tomorrow, and click the link in there to fill out the survey for us. Let us know how we did, and we'll get you guys set up with certificates. With that, we're going to go ahead and wrap it up. Thank you much for attending today's webinar, and we will catch you again next time.